Okay, all right. So I'm Tammy Billie-Stanton. I'm a specialist emergency physician. And this afternoon, this evening, we're chatting about POCUS, so point of care ultrasound in pediatric emergency medicine. And like most emergency physicians, I'm an ultrasound fanatic. It's very hard to do clinical practice with an ultrasound. I work at Rahima Musa Mother and Child Hospital. And in the emergency department. So I'm the head of the emergency department there. You might have heard about our hospital in the news a little bit. We've been having problems over the last couple of years, much like many of the state facilities. But we are very happy because we have an awesome ultrasound machine in our department. So despite our difficulties, we still get to sonar patients. I also belong to PECSA, which is a special interest group of the Emergency Medicine Society of South Africa. And I think that's why I've been invited to chat to you guys this evening about point of care ultrasound. So when we talk about point of care ultrasound, we just need to remember that it is not the same as formal ultrasonography. There are special points to point of care ultrasound. So point of care ultrasound is done at the bedside by the clinician. And we're not trying to make radiologists, radiographers, ultrasonographers out of the clinicians. We're trying to give an extra tool to the clinician to help them in making their diagnosis, to helping them come up with a better differential, to rule out certain, or to rule in certain diagnoses. So it will depend on what we are looking at. And also to help us with our procedures and with resuscitations. The nice thing about point of care ultrasound is that there's no ionizing radiation. It's done at the bedside, so we don't have to send our patient to the donut of death. So like the CT scan, we don't have to send them to another part in the hospital. It's repeatable. So if we find that the first ultrasound that we do at the bedside is not particularly helpful, we can repeat it in a few minutes or half an hour or so to help us with our assessment. And we can also go ahead and use it as many times as we like. It's not going to cost us, as long as there already is a machine in the department. So it's a fairly cheap tool once you've invested in using, in purchasing the ultrasound machine for your department. So we do use point of care ultrasound to rule in a diagnosis. We don't necessarily use it to rule out a diagnosis. And what do I mean by that? So we like to use point of care ultrasound for answering sort of binary questions. Is there free fluid in the abdomen? Yes or no. Is there a pericardial effusion? Yes or no. Is there cardiac motion? So during cardiac arrest, if we use it as part of cardiac arrest assessment, is there actual cardiac motion? Yes or no. So we do know that ultrasound is operator dependent. So as you become more skilled with your ultrasound, the diagnoses that you are able to explore and investigate obviously will become more advanced as your skill becomes more advanced. But it's also one thing just to reassure everybody. Everybody feels a little bit nervous at the beginning when you're picking up a sonar probe, but just get used to it. Put a probe on the patient and don't be shy to look for stuff. Can't hurt the patient, can't harm the patient to look. So what I'm going to do is try and illustrate a very common presentation for a child in the emergency department and how we can use ultrasound to aid us in the diagnosis. So this is little Kenny. Kenny is a kiddo who's come in. His mum says that he's had some nausea, a bit of vomiting, and some abdominal pain. He has lost his appetite since last night, and he's been feeling a bit niggly. Mum said he seemed to have a little bit of a fever yesterday, but she thinks the reason he has a sore tummy is because they were playing in the yard, and one of his friends took a tumble, and he fell over and got bumped in the tummy by the other kid's foot. So she thinks that there is a trauma component involved. So eFAST is one of the tools that we can use that is widely used in emergency medicine. So it stands for Extended Focused Assessment by Sonography and Trauma. And it is also a tool that we use pretty much every day in my department for our PEDS trauma cases. In my facility, we don't have any pediatric surgeons. So the PEDS emergency team in the emergency department, it's really important that our guys are skilled in being able to use the sonar. Also, because at the moment we don't have a functional CT scan. So it's really important for us to be able to use it to help risk stratify our patients. So the eFAST will take you through a number of views. Will help you look at the anterior part of the chest. So you're looking for lung sliding to help us diagnose whether there's a pneumothorax or if there's not a pneumothorax. We can also have a look at the right upper quadrant and at the left upper quadrant to see if there is any free fluid in the abdomen. And we'll also look on the other side of the diaphragm to see if there's a pleural effusion. So in a trauma patient, we would assume that a pleural effusion is a hemothorax. It also takes us through looking at the subxiphoid view. So we'll look at the heart to see if there's any pericardial effusion and is there cardiac motion and cardiac activity. And it'll also take us through looking at the pelvis to see if there's any free fluid around the bladder or in the pelvis. So we do exactly that. We put a probe onto little Kenny's chest. So the left side, you can see there's this strange pattern. And what you're looking at on the screen is the lung sliding. So this is the parietal and visceral pleura rubbing against each other, that bright white line in the middle of the screen. I don't know if you guys can see my arrow. This here is the pleural sliding line. The black line is the shadow from the ribs. So we're looking at pleural sliding. It's difficult because we're trying to examine and trying to comment on artifacts. So the artifact that we're seeing is pleural motion. So if there's good pleural motion, that implies that there is no pneumothorax on that side. On the right-hand side of the screen, you can see that although there's breathing, there's motion, there isn't this sliding sign, like an ants marching sign. So in a patient who has sustained some trauma to the abdomen, possibly the lower chest, we'd be worried about a pneumothorax. So clinically, obviously, it's important to examine the patient, but to use the sonar in conjunction with your clinical exam. So if you've got decreased breath sounds on that side and you find this picture, like what you are seeing on the right-hand side of the screen, absent pleural sliding, you need to be very worried about a pneumothorax on that side. We don't have to wait for a chest x-ray to confirm the diagnosis. We are able to clinically decide, is the patient hypoxemic? Is the patient very distressed? Do we need to insert a chest drain at the bedside? So that is the nice thing about point of care ultrasound. We use it in a similar way to a stethoscope. So much like we would use our stethoscope in conjunction with our clinical exam to assess our patient and to aid our diagnostics, the same way we're going to use our ultrasound probe to help us assess the patient. We then move on. So this little kid, we've decided actually both sides were normal. I was just demonstrating how absent lung sliding would look on the right. Then we then move on to examining the right upper quadrant. So the view on the left, the one that's labeled normal, what we're looking at is a view of the right upper quadrant. The white bright line is the diaphragm, with the liver moving in and out with breathing. The kidney you're able to see in good view below the liver, and we can see the tip of the liver as well. On this side, you can see there's no free fluid between the kidney and the liver. So in Morrison's pouch, there's no free fluid above the liver. So say sometimes fluid might accumulate above the liver, below the diaphragm. And we're also looking on the other side of the diaphragm to see if there's any free fluid, for example, a pneumothorax. So we do find a normal right upper quadrant, but I have shown the video on the right, which is how an abnormal right upper quadrant ultrasound view would look. We can see in this view that there's a lot of free fluid in Morrison's pouch. So that's below the liver and above the kidney. And the liver was essentially looking to be flapping around in a lot of fluid. So this is a positive eFAST. The right upper quadrant view has got free fluid. So we need to be worried about intra-abdominal injury. So we can definitely say there's positive free fluid, and we need to be worried about maybe there's a liver injury. We don't have to now go and diagnose what the size of the liver laceration is. That's not what is expected at our level. We would want to see is the hemodynamically unstable patient with blunt abdominal injury, blunt lower thoracic injury, and we're looking to see if there's free fluid. So fortunately, little Kenny doesn't have any free fluid in his belly. He had normal view. So we move on to the subxiphoid view. And what we're looking at here is we're putting the probe under the xiphisternum to see, is there cardiac motion? There's nice cardiac motion. And is there any pericardial effusion around the heart? And there isn't in this view. So we are excluding a cardiac injury. Clinically, we've done a good exam. Clinically, he's hemodynamically stable. There's good heart sounds. There doesn't seem to be any injury to his myocardium, and we didn't see a pericardial effusion. We now move the probe onto the left part of his chest, lower left upper quadrant, and we slide the probe down. So the white view on here, again, is the diaphragm. You're seeing a beautiful view of the spleen with a little bit of the splenic notch. His left upper quadrant looks completely normal. There's no free fluid between the spleen and the kidney. And there's also no free fluid below the diaphragm and above the spleen. So that's very often where free fluid will collect. So here, we're not seeing anything abnormal, which is good. I have shown a video on the right of how an abnormal view might look if there was a significant amount of free fluid. You can see that it is collecting here between the spleen and the kidney. And very often you need to make sure that you see all the way to the tip of the spleen as well, because free fluid can collect there. This is another view just to show us how splenorenal free fluid might look on the image on the left, as opposed to this space on the right, with what looks to be free fluid is actually fluid in the stomach. So this would have been mistaken for free fluid if you're not aware that there are some pitfalls. So the pitfalls are free fluid in the stomach can be mistaken for free fluid. And there's a few clues here as to telling us why this is the stomach. You can see the rugae in the stomach, and there's fairly turbulent flow, as opposed to on the left-hand side image, it's clearly free fluid between the spleen and the kidney. We then move our probe on to the pelvic view, and we have a look below the pelvis, and the view that we want to see is the one that we see in Kenny, which is a normal view, no free fluid. If we saw the image like what we see on the right, there's free fluid in the pelvis, we're obviously worried about intra-abdominal pelvic injury. If you know how to do an EFAST, then you know how to do a FASH. Now, a FASH is a really good tool for picking up extrapulmonary TB. So there's a study that was done in 2018 in South Africa, looking at point-of-care ultrasound for kids who've got a diagnosis of TB, hunting for extrapulmonary TB. Now, the FASH scan, focused assessment by sonography in TB and HIV, is not a new tool. We do use it fairly often in adults, but it's also a good tool in peds. So kids who have got ascites, it is easy to see on an ultrasound, because if you can do an EFAST, you can do a FASH. We also look for splenic microabscesses, which is an easy tool. This is not a difficult thing for us to pick up. And if you've gone on the basic ultrasound course, which teaches you to look at the aorta, so that's what this view is here, it's showing you periaortic lymph nodes. So you might think, well, why do I need to, examine an aorta in kids? Well, there are various reasons, including cardiovascular. But if we're looking for extrapulmonary TB, if the kiddie's got abdominal TB, this is an easy thing to be done at the bedside, and we don't necessarily have to book a formal ultrasound. So a FASH scan is really great. I'm moving on to another potential diagnosis. All right, so we don't see that little Kenny has got any evidence of pulmonary TB or extrapulmonary TB. So we have a look at his kidneys. We're looking at a sagittal view as well as a transverse view of his kidneys. Now, his kidneys are looking completely normal. However, if we did an ultrasound and we found hydronephrosis or hydroureter, we would be very suspicious that the kiddie might have posterior urethral valves, some congenital abnormality of his urinary tract. And history taking and clinical exam, including a urine dipsticks, obviously in the emergency department, is important. But this is a really easy thing to do. We're just looking It's not interventional. I'm not doing any procedure. I'm just looking at the kidneys. Stage 1, hydronephrosis is really mild. It looks very normal all the way to stage 4. Now, stage 4 is pretty easy to diagnose. 2 and 3 are sort of difficult. Stage 4, there's hardly any cortex left, and there's also a large hydroureter. Stage 1 hydronephrosis very often is difficult to pick up, but the more advanced you see it, the more likely there is to be some ongoing problem. This is an example of a hydroureter. You shouldn't be able to see the ureters on a normal point of care ultrasound. We don't usually. So if you're finding this with a hydronephrosis, you need to be worried about, is there posterior urethral valves as the cause of his urinary tract infection, and that's why he's presenting to the emergency department. So we move on. We didn't find any abnormalities on his kidney ultrasound, but we do find that he's very tender over the, sorry, my cats are being very naughty, right iliac fossa. He's got significant tenderness, hop tenderness, cough tenderness. And we do a pediatric appendicitis score. At the same time, we put an ultrasound probe on and we have a look and we see something called target sign. We put it on exactly where they have tenderness, and you'll see this large round shape. So they're trying to show you in transverse and sagittal view of the appendix. And if you're seeing this, you usually get point tenderness. This is a diagnostic of appendicitis. There's also periappendiceal fluid, which is highly suspicious. So you might see hard signs and you might see soft signs of appendicitis. You might see fecolith as well in the enlarged appendix. The appendix wall might be thickened. The appendix might be elongated. You might see appendicolith. So we very well might use the sonar to help us diagnose an appendicitis. He's probably a little bit too old, his age group for an intussusception, but if he was a little bit younger, if we had a kiddie who was presenting with typical features of severe pain, maybe that red currant jelly stool, and I haven't seen it that many times in my life, but I've seen intussusception more. If you were to do an ultrasound, you very well might see this picture, which is the involution of the bowel layers on each other. And it's also diagnostic of an intussusception. You can also see there's fluid and edema around the intussusception. And if you do find this on ultrasound, and it is intestinal and abdominal ultrasound is more complicated, but it is a slightly more advanced skill, but it's really great if you are able to pick this up in the emergency department. The last thing we're going to have a look at is we do a good genitourinary exam for the kiddo, and we find that he's very tender. We also notice that it seems to be that his right testicle is slightly more swollen. We have a look with the sonar and we see, so it's called a spectacle view. So you imagine that we're doing a spectacle. The left testis is homogeneous. It's nice and small. The one on the right has got a large amount of free fluid, not really a large amount of free fluid, it's enlarged, but a small amount of free fluid around the testis. We're also now putting on color flow to see if there's good flow. And at the moment, there doesn't seem to be the best flow as the operator is moving his hand. That's why you see that starry appearance. If you've put on color flow, the areas where there is flow, obviously there is good vascular flow to the testis, and it is unlikely that we're dealing with the torsion. However, on the right-hand side of the screen, the left testis, there's really good flow. On the right-hand testis, the left-hand side of the screen, you can see there's absent flow. So this is just normal color flow Doppler. And you can also do pulse wave Doppler as well. So in the end, what we've gone ahead is we've diagnosed that this kiddo has got a testicular torsion because we've been able to use our ultrasound at the bedside. Color power Doppler is really nice. It doesn't show direction. And it also is really good at having a look to see if there's good flow and if there isn't good flow. So it's a nice tool for the ED. Other things that we very well might use ultrasound for is venous access. So if we struggled for venous access for Kenny, there are many, many different modalities: lung ultrasound, cardiac ultrasound, GIT, neuro, looking at skin and soft tissues and bones, looking at the airway, looking at the liver. So there's thousands of different applications that we can use the tool for in our department. I just want to encourage you, pick up the probe, don't be shy, go and attend a POCUS course, learn how to do the basics, learn how to use the machine, and then practice, practice, practice until your heart's content. And that's the end of my talk.